With us today, we have Dr. Barbara Wirostko. She's from the University of Utah, another one of our clinical care networks. She's the at Moran's resident research director and adjunct professor of ophthalmology and biomedical engineering. With that in mind, I'm going to let you take it over there. Thank you.
Thank you, Julia. So I was listening before and there were a few comments that came up. One was about seizure medication in narrow angle. So generally narrow angle is something that affects older individuals, and it has to do with the anatomy of the eye. So back to the question about the seizure medications in a young child. Think of glaucoma. Glaucoma is a bit of a wastebasket. There's a lot of different causes and different types of glaucoma. But in terms of the narrow angle, it's unusual for younger individuals and children to have narrow angles. If a child and an infant has glaucoma with under the first 2 years of age, it tends to be congenital glaucoma. And again, there's anatomical deformities to the front of the eye. So again, a little bit different than the type of glaucoma that affects Sturge-Weber children later on, and also different from what the type of glaucoma or raised intraocular pressure that seizure medications would cause. The other thing that I wanted to call out before I go into my deck is something that Dr. Metri brought up about having these children go under general anesthesia. And I think it's so critical to have a collaborative team, because while that child is under general anesthesia, you can not only do the lasers, but you can also do an eye exam. And generally these children need evaluations under anesthesia to actually be able to get a thorough exam of the eye. And for all the reasons, as you know, it's very challenging to get little kids to stand still and to examine them, and even to check their pressure. So again, take advantage of having your child under anesthesia and try to get as much accomplished as you can at once. The other hat that I'm wearing for this presentation is being the Chief Medical Officer and co-founder of a company called Cularis Bio. So we've been working with the Sturge-Weber Foundation now for about 2 years, and thank you, Karen, and everyone there at the foundation. And in particular, we're developing an eye drop that is going to hopefully help lower IOP, and specifically in the types of glaucoma that present in Sturge-Weber children. So at Cularis Bio, we're seeking to develop novel, innovative therapies that can treat and prevent serious and debilitating ophthalmic diseases. And we're really looking at therapies that are first in class, so we're not necessarily just repurposing medications. What is glaucoma? So you hear glaucoma being thrown around. Well, it encompasses several different etiologies and different causes, but it's a slowly progressive neurodegenerative disease that causes damage to the optic nerve. And what ends up happening is you lose vision. You not only lose vision, but you lose visual field. The main cause of glaucoma is elevated intraocular pressure. Now, there is a type of glaucoma called normal tension glaucoma that tends to affect older individuals, in their 50s, 60s, 70s, where the IOP is not that elevated. And for that type of glaucoma, we think it may be more vascular related and inflammatory. But in a nutshell, if you've got progressive damage to the optic nerve, we classify that as glaucoma. So when we think of the pressure, we think of the pressure actually putting damage or stress on those optic nerve fibers. And on the left side, you see sort of a healthy eye, and then you see this schematic of fluid or aqueous building up. It's not really true because it's not the back of the eye, but it's the front of the eye where the aqueous builds up, but it puts stress on that optic nerve. And think of the optic nerve as sort of a fiber optic cord that comes in with all these long nerve fibers. And on the right, in those two photos, you've got a healthy nerve on the left of the right photos compared to the right. And what you're looking at is that optic nerve head. So you've got the rim, which is the nerve fibers, and then you've got the vasculature that's coming through. The difference between those two photos is basically the difference of, say, a car wheel to a bicycle wheel. And that thin rim, that really thin wheel, or that thin layer of nerve tissue, and those blood vessels are right at the edge, is where you're losing the nerve fiber. And those are the retinal ganglion nerve fibers. So when we talk about vision, what is vision? So, and this can sometimes be confusing too, because you don't necessarily need to not see to be blind. So this visual field, which is a measure of the peripheral vision, is in someone who has glaucoma. It's actually the right eye. They've got nerve loss. It's the right visual field. And they have a very, very constricted visual field. And this is what happens with glaucoma. You tend to lose the peripheral vision first. So a lot of times patients don't even know they have it. It can be asymptomatic. It can be without any pain. And as that vision constricts, that patient may still have 20/20 vision. So this patient would be classified as legally blind because they have such extensive peripheral vision loss, but yet their vision is 20/20. So we often refer to it as the sneak thief of sight. So this is sort of your general type of glaucoma. Acute angle closure is different. That tends to be a rapid increase in IOP and painful. So again, very, very different presentation. Your eye will not tolerate a rapid, sudden increase in pressure, but it will tolerate a slow increase in pressure over time. And again, that's why this often goes undiagnosed. So what makes up intraocular pressure? So here we have on the left, number one is the ciliary body. So we talk about something called fluid or aqueous humor. The ciliary body is a vascular structure in the eye that is constantly making intraocular fluid or aqueous humor. And that fluid flows. It flows from the ciliary body through the pupil and out through the angle. So when you look at number two, that is in fact the angle. So we talk about an open angle versus a closed angle. A closed angle is mechanical. Imagine that pupil, imagine that iris, the colored part of your eye, falling forward and actually closing off the angle. And that's an acute angle closure attack. And I'm not going to talk about that because it's really very different from what you guys are concerned about. So here, this is open angle. So the angle is open. The fluid or aqueous flows from the ciliary body out through the pupil and out through the angle. The angle is made up of a vascular system called the trabecular meshwork, the uveoscleral pathway, and collector channels. So now think about a bathtub. And my co-founder and colleague and dear friend who started the company with me loves to use this analogy. So that bathtub is always on. And that nozzle is always producing fluid, and the water is always coming out of that fluid, or fluid is coming out of that nozzle. So that's your ciliary body. Fluid's coming out and it's going down the drain. If you suddenly close off the drain, that is angle closure. But if the drain is open, but the pipes leading from that drain are clogged, narrowed, sclerotic, or have something in them, you will not get fluid going through. That's the trabecular meshwork that then goes into this episcleral vasculature. So on the right-hand side, we have, sorry, my dog, we have the episcleral vasculature or episcleral venous pressure. So again, we've got this angle, trabecular meshwork, the fluid flows out through the trabecular meshwork into these collector channels that are all this vasculature on the surface of the eye. And in that vasculature is resistance or pressure, and that's the episcleral venous pressure. So what composes IOP? IOP is made up of the rate of aqueous that's made, the formation, the nozzle, the uveoscleral outflow, which is basically the outflow, the trabecular meshwork, and then the resistance. So if you've got fluid flowing through these pipes and it can't get through the pipes distally, you then have elevated episcleral venous pressure and your IOP goes up. Interestingly enough, if you look at this equation, which is called the Goldman equation, episcleral venous pressure is the largest component of IOP. 2/3 of IOP are made up by episcleral. We realize that there's 3 areas in glaucoma where EVP, or episcleral venous pressure, plays a role. Normal tension glaucoma, we're now believing, because IOP isn't that elevated, but yet studies have shown that these patients tend to have higher EVP. We also know that if we do surgery and bypass that drain with a MIG, that's called a minimally invasive glaucoma surgery, and it's a shunt or a stent in that trabecular meshwork, that we still can't lower the pressure. So even if we stent that trabecular meshwork, sometimes 360 degrees, which is exactly what some of the surgeries your children will have with goniotomy or different surgical procedures, we still can't get fluid out. So there must be something resisting beyond that drain or that angle. And then thirdly, it's the episcleral venous pressure in Sturge-Weber. Current therapies, as you probably, if any of your children have glaucoma, know that it's very, very difficult to control IOP in the Sturge-Weber patients. And predominantly the reason is that everything we have to lower IOP works on either the fluid being made or the trabecular meshwork outflow or uveoscleral outflow. We don't have any medications that actually work at the distal area, that resistance, that help to open up those pipes that are away from the drain. That's why we're looking at that area with Cularis. So what happens in Sturge-Weber patients? Why is it unique? What is going on with their glaucoma, with your children's glaucoma, if in fact they do end up getting glaucoma? As you heard from dermatology, very often, if there is a port wine birthmark around the eye, that child is at a higher risk for glaucoma, and it's because of those vascular anomalies. The glaucoma in Sturge-Weber can be very, very high, and it can also be very, very challenging and difficult to control. It generally is due to blood and vascular engorgement, those vascular anomalies that impair the outflow in that episcleral distal outflow channel. So here again, we've got a schematic, and this is on the lower left-hand side. It depicts all these blood vessels and channels. So find the angle. There's your ciliary body. There's your drain, saying the trabecular meshwork, and it's draining into these veins, into these channels. And the fluid, which is clear, actually ends up merging with blood as it exits the eye on the ocular surface. So the fluid goes from the front of the front inside the eye through that angle or the trabecular meshwork into those blood-filled channels. And on the right-hand side, you can see those blood-filled channels. So what we look for when we diagnose anyone with this type of glaucoma related to episcleral venous pressure, we're looking for vascular engorgement of the conjunctival vessels, because that's a telltale sign that those vessels are engorged with blood, and the fluid can't get out because there's so much blood in those blood vessels on the surface of the eye. The other thing we look for is we actually do an exam, again, in younger children under anesthesia, to look at that angle or drain, because we can sometimes see blood in the angle backing up all the way to that trabecular meshwork, showing us that in fact there is all this vascular engorgement around the eye, impeding the fluid from leaving the eye. So why is this an unmet need? Well, as I mentioned, despite available therapies, glaucoma still remains a leading cause of preventable blindness around the world. In fact, it's the third leading cause of blindness globally, the first being cataracts and macular degeneration globally. The only modifiable risk factor for glaucoma is intraocular pressure. That's all we have is medications that lower intraocular pressure. And as I mentioned, out of all the components, the fluid being made, the drain, and the episcleral vessels, this fourth component, episcleral venous pressure, is wholly unaddressed by what we have available today. The therapy that we are looking to develop with Qlaris is QLS 101, and we're hoping that what it will do will target the episcleral venous pressure, vasodilate, relax that venous engorgement, reduce that resistance, and then help lower IOP in that via that mechanism. It's a new paradigm. It's no one has tried to target EVP before. It was invented in the laboratory of Michael Fausch, Professor Michael Fausch, who is a very well-respected professor of ophthalmic research at Mayo. And we've in-licensed that compound from Mayo. We're hoping it's going to be a once a day, or maybe in Sturge-Weber children, a twice a day drop that is going to fulfill an unmet need. It'll be a first-in-class therapy with a new mechanism of action. And because it is unique and because it is different, it's also additive. And this was something that Dr. Michael Fausch has shown in numerous animal studies. In fact, he was developing this compound for about 12 years before we in-licensed it. And the amount of data that he has in mice, dogs, monkeys, rabbits, even cadaver human eyes to show the mechanism, to show its efficacy, to show its tolerability, and also show its additivity to current therapies is really quite impressive. So our clinical program, I'm sure you're probably wondering where we are and if we're able to actually, start using the medication. So in order to develop any drug in any area, you have to do a clinical development program. And the FDA and the EMA and regulatory agencies around the world want to make sure that it has efficacy, but even more importantly, that it is safe and well tolerated. So that is where we're currently at. We are conducting our first in human studies. Our first study is QC201, which is where we're looking at primary open angle glaucoma and ocular hypertensives. These are patients who are 18 years of age and older. Generally, this patient population is, kind of your 50 and 60-year-old patients that have glaucoma, mild glaucoma, and or ocular hypertension. So they're being followed for glaucoma. And we have an active comparator. It's a randomized, masked controlled study, meaning the patients and nor the investigators, nor we as the sponsors know what the patient is getting. And they're either getting timolol, which lowers intraocular pressure with a once-a-day eye drop, or they're getting one of 3 different doses of our compound once a day. And it's a 28-day study. We're actually almost fully enrolled in that study. We have one more patient to go. So we hope to read out the data within the next 2 months. The next study is our normal tension glaucoma study. Again, I mentioned that there is nothing actually approved to treat normal tension glaucoma. And again, a difficult type of glaucoma to treat. We've got a study ongoing. And then lastly, we have a study ongoing in Sturge-Weber adults. So we're working with Dr. Sharon Friedman down at Duke. We're going to have only a small handful of patients in this study. And it's really to see the safety and the tolerability of 2 of our concentrations in Sturge-Weber patients who are adults. Again, the FDA wants you, necessitates you actually to start in adults first for various reasons. Once we show that we have a well-tolerated and efficacious drug that does show some IOP lowering, we plan to go into juveniles. So that'll be the next study that we're going to start and kick off this year. So we're going to have roughly 5 or 6 sites. These are, clinical care network sites. We're working with the Sturge Weber Foundation to identify those sites. Those are pediatric glaucoma specialists who treat Sturge Weber children. And we'll be providing more information as we move along. So with that, I'm happy to open it up to any questions.
Thank you so much, Barb. That was a great talk. We really do appreciate you